Good morning. Thank you very much, Chairman and Co-Chair, for introductions. So my talk will be about the head split in proximal humeral fractures, how to manage this. Probably it's either safe or repressed, right? So about the incidence is less than 5%, but it's occurred because there was an impaction of the humeral head on the glenoid or the acromion. The spectrum can be from minimally displaced like this, or it can be displaced. As you can see, a double shadow sign on the head. You see two heads on the X-ray, or you see the pelican, the bird pelican sign on the X-ray, just like the beak. The Marcus Scheibel classified it into 4 types. Type 1, which the fracture line occur in the posterior half of the humeral head, that leave the larger fragment in the anterior part. In this kind of cases, you will see the pelican sign on the AP view. The type 2 is a fracture line that located in the anterior half of the humeral head. Now the larger fragment located posteriorly. You will see the pelican sign on the axial view, axial view. For the third, the type 3, there's a central fragment free or loose on the humeral head. And the type 4 is severely comminuted of the humeral head. So the option of treatment from conservative to fixation, like hemiarthroplasty or reverse total shoulder. But as a surgeon, we are looking for which one has the least complication and the best function. That probably how to we decide which kind of treatment. Let's look at the complication first. So the main complication is osteonecrosis. There are a range of report from 4 to 44%. But from what I review in the major literature, it occurs around 1/3 of the patients who have the head split fracture that have the avascular necrosis. So, but if you look at the fracture characteristics, I saw a report that if you get a complex fractures, it means combinations, the incidence is about 40% of the avascular necrosis. But you get a simple fractures, the chance is less. So what does it mean? So young patients, simple fracture, fix it, don't repress it. That's the data we have. What else are the risk factors of avascular necrosis? First, we know it's complex fracture pattern, right? Then the presence of anterior dislocation, the anterior, the associated soft tissue injuries, and the choice of surgical approach that you don't do it well, you destroy some blood supply. So look at the implant used. LCP versus hemiarthroplasty. See this LCP group create more complication in terms of avascular necrosis and screw cut out. This paper report the revision surgery occur 45% in the head split group. Why if you do hemiarthroplasty, the revision surgery is only 4.5%. So if you look at all the equipment, the plate fixation create more complication. And if you look at these literatures on the 30 patients, 24 RF, but the number of arthroplasty is a little low, 6, but they report a similar complication rate. But the OIF report also necrosis 42%, and the reverse total shoulder require less revision surgeries, and the function is better. So in this literature, kind of favor of reverse total shoulder more than the ORIF in head split fractures. How about the functions? Look at this case. What will you do if this your case? So the surgeon did pretty well in reductions and fixation, but it's just unlucky of the patient. Patient developed osteonecrosis, and this is what he have. So if you think, hey, let's fix it first and repress it later, it has been proved that the revision surgeries for like a salvage procedure after ORIF and convert into the arthroplasty create a poor result compared you do primary arthroplasty in the proximal humeral fractures. So what your job is to choose who are the candidate for shoulder replacement or who are the candidate for fixation. Not just go for fixation, not go for the replacement. So the replacement proper in the patient who have severe comminution, marked articular damage, associate this location pre-existing osteoarthritis or cup tear arthropathy like our patient had before. So in severe comminution, look at this case. Patient 64 years old. So I did the reverse total shoulder for her. And this is her 3 days ago. She came for follow-up at my office. This is, to me, in my hand, it's more predictable result. In very severe comminution osteoporosis. So marked articular damage. In this kind of case, you see, this is marked articular damage for sure. But patient have a reasonable greater tuberosity. So what I do hemiarthroplasty, and you refix the greater tuberosity. Because greater tuberosity is the key. If you can save it, it have a good quality, and you can create a healing. You get a good functions. Like this case, like that. So we did hemiarthroplasty, and this is her at 4 months. This is another case. I mean, we did, but this is what happened. He only abducted his shoulder only 20 degrees. Why? You see, the tuberosity is gone. It's resolved. So the main function, I mean, if you want a function for the hemiarthroplasty, besides sitting the prosthesis well, you need to create a healing of the greater tuberosities. So, but what we can expect from the hemiarthroplasty is an excellent pain relief procedure, but the result sometimes is inconsistencies. So the poor outcome when you do a hemiarthroplasty, you overstuff the processes, humor length more than 10 millimeters, or you create a retroversion more than 40 degrees, and you get a malunion or resorption of the greater tuberosity. So it's not going to be good. So the ideal indication for hemiarthroplasty in a young patient who have unreconstructible proximal humeral fractures. I didn't say in young you have to repress. You try to reconstruct first. But if you can't, this is the way to go. So, but again, it can be a salvage procedure in the elderly people who have like quality of life would not be compromised by having limited functions. Because why? It have low complication rate. Let's see this case, 84 years old, see her underlying. So say, okay, let's conservative, let's hemi. But after I talk with the patient, see that CT scan, after I spoke with the patient, she want to have a good quality of life. So what we did for her, this is her at 6 months on the right shoulder. I mean, you give her back a good quality of life, even it's the last period. But if she understand the relative, understand everything, what we're going to do, accept the rest, if you can do it well, it creates a good quality of life for the patients on the remaining of her life. So how do we choose between hemiarthroplasty and reverse total shoulder? Well, if you have intact or repairable rotator cuff or minimal comminution of tuberosity, it's kind of favor of a hemiarthroplasty. You reserve the reverse total shoulder in non-union or those comminution of the tuberosity or irreparable rotator cuff tear. So, summary number 2, joint replacement indicate in elderly people complex fracture pattern and you can't reconstruct the bone. Mainly it's type 3 or type 4. This is another case. You really can't reconstruct this, right? So we replace her. It's like this. If you want to fix it, it's better than do conservative in this case. I mean, Ajahn Jack technique might be a good thing to try, but number is still too low for me to follow him. I will wait and see. I listen, but I will wait and see. Okay? By the outcome of the reverse total shoulder is far better than hemiarthroplasty in the proximal humeral fractures. So if you look at the trend of the arthroplasty, the hemiarthroplasty is decreasing and reverse total shoulder replacement increasing in US, also in Thailand as well. So again, this is a summary that I show. Okay, looking some gray zone. I have only 22 minutes. So this is my case, Ekavit case, not Thai case. The first and the third case are Falang, and the second case are Thai. So, and this is what we did. Looks like him to heal well, right? 4 months later, my case developed a vascular necrosis. Ajahn Ekawit case healed very well. And Ajahn Nathai case got unlucky. Need another surgery. So, this is what happened. Winner, loser, and unlucky man. So what I'm trying to say that the factor of successful is so unpredictable in head spread fracture in the like a 50-something years old. So you need a good decision-making, skillful surgeon, and of course you need a luck to help you practice. Thank you very much for your attention.